Welcome, friends, and thank you for tuning into another episode of the Optimal Health Program. I have some wonderful information for you today. I have a terrific guest, a gentleman I've known for many years and referred to for many years. He's a podiatrist, our favorite podiatrist, Dr. Anthony Ferraro, and we're going to talk about a variety of common foot conditions, what the latest and greatest is in terms of evaluation and treatment and therapy. And wonderful to have you on the program, Anthony. Thank you so much for coming on the show.
Thank you very much, Dr. Calapai.
It's a pleasure to have you. So as we talk about different conditions and we see so many different things evolving over time, years ago, I don't think we saw as many issues with the feet, whether circulatory problems, ligament, degenerative, arthritic problems, plantar fasciitis. It seems that everybody's got some evidence of foot degeneration and, plantar fasciitis lately. Which do you see to be some of the most common things that you're treating now?
So, being a generalized podiatrist on Long Island, one of the most common things that we see is plantar fasciitis. Plantar fasciitis probably equates to better than 50% of all of our new patients that come into our offices.
Yeah.
Yeah. Staggering.
Yeah.
We also see a lot of diabetic neuropathy, diabetic foot care. When patients have peripheral vascular disease as we age, not only do we have arthritic disease, but we also have vascular disease. So we see a lot of patients with pain in their lower legs that equate to foot pain with many different pathologies that we see in our offices.
Correct. Loss of blood flow can create a variety of different problems, but if you don't have good blood flow with oxygen, vitamins, minerals, and hormones getting down to all your tissues, tissue degeneration occurs, ulcers can occur in and around the pad of the foot, the toes, the list goes on and on. We tell all our patients that you have to have a good podiatric evaluation done and visits even before having, problems, because you want to make sure that these things aren't going to evolve. Look at all the people that have bunions and certainly arthritic changes of the feet, Morton's neuroma. So the list goes on. And as I say, there are more problems now than ever before. I read an interesting article this morning because I go onto Google and I create a little reminder. So I set a parameter as to what I want Google to remind me of if the new research is coming out. And now statistics are saying over 2.2 million people are becoming diabetic every year. It used to be 1.5 million people per year. Now the numbers are going up. And this is scary because it damages every part of your body. So, we'd like to be comprehensive in understanding how we can prevent these things and how we could help to correct and fix these things. Are there ideas that you have with patients on prevention in terms of obviously getting them to wear better shoes, more comfortable shoes, things that aren't going to kill their feet?
Sure. Obviously, shoes are very important when it comes to your feet. The average person probably walks around 4,000 to 5,000 steps a day. Most patients don't change their shoe gear as frequently as they should. Sneakers obviously are more comfortable than shoes, definitely better for the feet. But preventative care, as far when we talk about pedal pathology, really the diabetic patient preventative care, 1 to 2 visits a year without neuropathy. If you have neuropathy, you probably be seeing the podiatrist every 2 months. A patient with neuropathy should not be taking any sharp instruments to their feet to trim any nails or calluses. Yeah. A slight little cut or laceration in any of your toes can lead to an infection, which can lead to either a gangrenous infection or osteomyelitis, a bone infection.
And fungal infections are very common in the diabetics as well. So when they get the cracking of their skin, and fungal infections can be big issues for them, much worse than a person who's non-diabetic.
Correct. Diabetes, you're considered immunocompromised, so a slight athlete's foot infection may not go away with using over-the-counter topical antifungals, which may prompt you to visit a podiatrist, and you may need a prescription strength topical antifungal to help with a fungal infection that you're prone to develop because you are immunocompromised with diabetes.
As well, the fungal infections of the toenails, you see a great deal of people having issues with their toenails and problems that arise as a result of neglecting their feet. So, for all patients, and certainly for the diabetics, we want to get them to have the evaluations done so they can, head something off at the pass rather than allow it to develop to become much more of a significant problem.
Definitely. Nail fungus is a very interesting topic because there are a lot of treatments out there. Specifically now, a lot of people advertise for laser therapy. And we have patients coming into the offices. Oh, I've tried topical medication. I've tried oral medication. I'd like to have laser done on my nails. Mm-hmm. And you really have to pick the patient and their toenails wisely because not every patient is a candidate for laser. And there is no 100% cure for fungal nails, mm-hmm. which is, it's very interesting. Big Pharma has not attacked that yet.
Yeah, it's interesting because the number of people who have that over time as they get older, has been skyrocketing over time. So, I think that partially the mechanism, and certainly for diabetics, we've got to control their diet, cut the carbs down, get them to do exercise, get them to fine-tune their diet, exercise, and, correct hormone decline when it occurs. I think people should go for some massage and physical therapy and have that done to their legs and their feet just to enhance circulation. There are a variety of different things that people opt to do as well now. Some people are using these vibrating devices where it sits there to create the vibration in their feet to help to improve circulation. And even those individuals that have ulceration, I know that some of the forward-thinking doctors and podiatrists are using techniques to try to enhance oxygenation of the feet. And in many cases, people with ulcers can go for hyperbaric oxygen therapy. So there's a lot, I think, that can be done. It's just a matter of trying to catch things early. And this holds true for every medical problem that exists. The earlier you catch something, the easier it is to correct and to prevent from becoming a very, very bad problem.
Correct. Hyperbaric oxygen, it is becoming more and more readily available, and especially here in downstate New York, mm-hmm. we have several wound care centers on Long Island, in Queens and Brooklyn as well. And hyperbaric oxygen, if you're a diabetic and you have an ulceration with an underlying bone infection, you will have access to hyperbaric oxygen because of insurance standards. Not every ulceration will allow a patient to have what's called a hyperbaric oxygen dive or treatment. Mm-hmm. But if you have an underlying bone infection, that is an indicator for the insurance to offer that to you, and it's a great treatment.
Correct, yeah, osteomyelitis. So many years ago when I got certification, I went down to, I think it was Charleston, and there was a great training course in hyperbarics. And for a long while, when I had my Manhattan office on 53rd and 5th, and in East Meadow, we had hyperbaric chambers, and they work really well to flood oxygen into all of your tissues without it being blocked and help to heal diabetic ulcers and leg ulcers and foot ulcers faster, as well help to kill the osteomyelitis, the bone infection. But it's a good comprehensive, adjunct to a variety of different therapies. What are some of the techniques that you like now compared to what was available years before for some of the things like the plantar fasciitis? Are there surgical procedures to help to create a release of some of the damage in the tendons and such?
Yeah, so years ago, patients would present to podiatry offices or their medical doctor's offices with heel pain. They would be diagnosed with plantar fasciitis. They would try your standard conservative care, stretching, physical therapy, oral and topical anti-inflammatories. When all the conservative care failed, they would discuss surgical options. And the surgical options, a lot of patients who have plantar fasciitis also have calcaneal heel spurs. Mm-hmm. So at that time, they would go in surgically and resect or remove the plantar heel spur, thinking that the heel spur is what was causing the pain. Mm-hmm. After years of research, we've now known that it's not the heel spur that's necessarily causing the pain, but it's actually the ligament, the plantar fascial ligament, that's attached to that part of the bone, which is very, very tight and taut. It's actually pulling on the bone, and bone grows under tension. So the tension is actually causing one to develop a heel spur. So now we go in and we just cut 2/3 of the ligament off of the heel, and patients do very, very well with it. It's an endoscopic procedure. It's a minimal incision, and they're back on their feet within a couple of days.
That's wonderful. And imaging, I guess, is far greater now than it's ever been before, whether we talk about MRIs and on some of the techniques, you could actually really see the defect or what's going on within those tissues.
Correct. Standard x-rays now are no longer a thing. We now have digital x-rays, so better advanced zooming into the image, ultrasound, MRIs. The technology is incredible from where we came to where we are now.
Wonderful. So for those individuals that have bunions and have distortion in arthritic toes and some of the hammer toes, I know we've seen a great deal of that over time, and I think that over many years, the typical issue where women would kind of cram their feet into these tiny little shoes with these pointy little shoes where their toes would be in some ungodly positions to create all this distortion, ligament tendon degeneration, grinding, between the joints has created a lot of problem. You don't see that as much anymore, I think.
Yeah, people are definitely more aware and cognizant of the shoes they're wearing, the comfortability. And I'd like to think that most people, if they put on a pair of shoes and they're painful, they don't feel comfortable, they don't wear those shoes. As far as bunions and hammer toes, interesting topic. Hammer toes. So a lot of hammer toes, you can actually help prevent the progression of the deformity if you catch it early on. Most hammer toe deformities are a muscle imbalance. The others are strictly arthritic in nature, but if you have a muscle imbalance, you can actually have a very small minor surgical procedure that's done in most offices. And we cut the flexor tendon or the tendon that's on the bottom of the foot by the toe, and it allows the toe from a contracted position to straighten out and look normal again. It's a small little procedure that's done in the office, and this is for a very early on contracture of the toe. If you leave that contracture over an extended period of time, a couple of years, the joint tends to become arthritic, and once you have an arthritic joint, you can no longer just release a tendon to release the contracture.
Right.
Now, you're looking at more advanced bone surgery where you have to remove a portion of the bone. Sometimes you need to put an implant in between some of the bones in the toes. More advanced. But if you do catch it early on, there are modalities that can really be very, very effective. Unfortunately, a lot of patients don't come in time, and by the time they present to the offices, they already have arthritic changes in the joints, and now we're looking at more advanced surgery.
Yeah, so once again, the ultimate, the smart mechanism is to evaluate your body before the problem occurs. If it starts, then of course you want to be able to get that dealt with earlier and in a minor fashion, as opposed to having a bigger problem to deal with. And with bunions, do you still see a lot of bunion surgeries?
Yeah, we see it. A ton of patients come in with bunions. My sole predictor, whether or not we go on to treat them surgically or not, is pain. If you do not have pain, I tell patients, forget about the way that the foot looks. The indicator to proceed with surgery is pain. I'm very conservative in that respect. Maybe a little bit too conservative, but the reason is that you don't want to take someone to surgery who has no pain. And look, no surgery is benign. You can always have some degree of pain, after the surgery. So we're very, very conservative with that. But there are a lot of better modalities and bunion surgeries called bunionectomies that are available to us now that weren't available to us 5, 10, 15 years ago.
That's terrific. So we're going to put the word out for people who want to call in and ask a question of myself, Dr. Ferraro, 888-420-9272, 888-420-9272. If you are watching on Instagram or TikTok or YouTube or any of the other platforms that you're listening in on, certainly you can give us a call at the office or email, text us. How does that work, Frank? I know we get text from Instagram.
So,
right?
yeah, from basically our stream, right?
Okay.
That's live on Instagram. People can comment if they see it up on the story, anything, or if they DM you, any way. If they just want to reach out on any of your socials, TikTok, Instagram, Facebook, we can get all of those messages, as well
Excellent.
as the YouTube link.
I'm very glad I have you here steering the ship, because without you, I wouldn't know how to do any of this. It's way too complicated for me. So, you're the best at this, and your wife, Sabrina, does a terrific job as well. So I have to thank you both over and over again for making this possible, making me look good and sound good.
It's easy.
So, yeah, I think for everything that I've talked about over so many years, we want people to take charge of their health, learn about their body, optimize their health, prevent problems from occurring. We like people to go for physical therapy and activity and exercise that can help to strengthen their muscles around the joints and such. So, unfortunately, too many people have issues with their feet and their ankles. You see this all the time, and the ankle joint and the toes of the feet are easy joints to break. And I've told people forever to watch very carefully how you're stepping off a curb, how you're going up and down stairs, getting out of a car. God forbid there's black ice or some of the slippery surfaces that you're walking into. Just make sure you're cognizant of where you're walking so that you can prevent some of these things from occurring. And every year we see patients that slip and fall and break their ankle and break their leg, just especially this time of year when the weather's cold out and you're seeing fluctuations in temperature, and all of a sudden you'll drop down to freezing temperature. A year or so ago, I fell into my own trap, per se, and I still have a big Dodge Ram TRX pickup truck because I like the whole pickup truck thing. I never thought I'd ever have a pickup truck when I was younger, but it's terrific to take on the beach. Friends and I, we go out and go fishing off the beach in Montauk. We'll drive on the dunes, find a secluded spot, and have a wonderful day. And with my friend Mike, and he might be listening, we have the greatest time. We've done this for years. So I was getting out of the car, didn't really look. I guess I was preoccupied, and I didn't step down onto this running board metal thing. And I decided to take my left foot, put it on, the driveway. Unfortunately, there was ice there, and I ended up slipping. Legs went up in the air, head came down, and I hit the running board with the back of my head. And for a moment, I sat there thinking, wow, did that just happen? I said, wait a second. Okay, well, let me just see if I've got a bump on my head or if I'm bleeding or anything. Strangely enough, there was no bump. And I hit it hard. It wasn't just a tap. Sat there for another minute, said, well, I'm not bleeding. I have no bump on my head. How weird is that? And then I kind of thought back to when my mom used to tell me that I had a thick head, and I didn't really know what the thick head thing meant. And I know my mom's listening right now. So I didn't really know what a thick head meant until I hit my head and cracked it hard on the running board of the truck, and I had no problem, no issues. So thank God I have a thick head. Okay, so phone lines are open, 888-420-9272. If you'd like to call and ask a question, you can do so now. Certainly if you're on Instagram, you're on TikTok, watching live, YouTube. We've had some really great response. And honestly, I'm very, very surprised as to what you're able to show me from our people following us. Now, I've mentioned 34, 5+ years of doing radio. The only mechanism of watching response was to look at my website and to see people hitting the website right after the radio show Saturday morning at 8 o'clock and at 6 p.m. on Sunday, you would see a big surge. But that was really all we were able to see. Now we can see numbers of people that are liking and following and favorites, for the videos and such. It's really terrific. And people that like one video will like another. And I could just watch all this happen, of course, because of what Frank and Sabrina are doing. So it's kind of amazing to see how many people are interested in the different topics. And we also put the word out to people. If you want to hear about a topic, let me know, and we'll talk about that and do a program on that topic. So the whole idea is to be here for you, to educate you and give you a great idea as to what's going on in the world of comprehensive medicine. Alrighty, so let's see. We have
So all we have right now is the live chat is saying Montauk is our pill for a healthy mind, which relates to a healthy body.
Absolutely.
And someone else said Montauk is the truth.
I love Montauk, and I've been going out there since I was a kid. My dad, rest his soul, used to take my mom and my sisters out there when we were wee little kids and walk around and go to Gurney's. That was a big, exciting trip for us, and walk on the beach, walk on the jetty. One of the things I loved to do, because every August they had this gigantic shark fishing contest, was to go out there, and walk along where the boats are, pulling these sharks in. I was just completely fascinated by sharks. So Montauk has been a favorite of mine for a very long time. I still go out there. I'd rather go out there even off-season when it's not as crazy, not as crowded. I have friends that live out there. A good friend owns an excellent, I call it a surfer dude shop. It's the plaza there where you walk down the steps and you can get your T-shirts and you can get your sunglasses.
It's a good ice cream spot there.
Yeah, great facility there. Sunday donuts. So it's a wonderful little town. And I go out there just to chill, and when I can get on the beach and just drive out there and sit out with friends and, make a little barbecue, have some fresh caught fish and stuff, it doesn't get better than that. So we've done a ton of that, and we'll continue to do that forever because Montauk is the place. Okay, once again, phone lines are open, 888-420-9272. Give us a call, give us a text.
We have a question. A woman, Debbie, from Instagram said she just has a question about arthritis and knees.
Okay.
Really bad arthritis. Could you help me with that in my knees?
Sure. So people that have arthritic knees, over time, degeneration occurs, swelling occurs. The best test to understand what's happening there to the nth degree would be an MRI, because that'll tell us about the outline or, wear and tear on the bone. And some people have some bone wear and tear, some people don't. And their arthritic knee is more correlated with damage to the meniscus, the cushion in between the bones, the figure of 8 cushion. Other people have tears of the cruciate ligaments that crisscross inside the knee to hold you in position forward and back. The collateral ligaments on the medial side, middle, or lateral side, where the fibula attaches. So we want to look at the entire picture. That's why the MRI is such an important test. So depending upon how much wear and tear is there, if it's very mild, we might opt to do PRP, platelet-rich plasma, where we take your blood, spin it, and 7 growth factors are there within that spun blood, and we inject that into the area to create some repair. And your body might take that, lead and improve your condition. Now, PRP doesn't last forever. It usually lasts and create its benefit over the course of about a month. So if it's a very mild mechanism on the MRI, that might be fine. If it's more degeneration or tears of the meniscus and beyond mild, then we opt to do stem cell therapy. So we take your cells from your body, and it takes about 1.5 minutes to extract, and spin them for a half hour in a high-speed 4,000 RPM centrifuge, and separate red blood cells on the top of that spin, your plasma, which all your cells are floating around in, and stem cells on the bottom. Take them out, inject them into the joint, and for other people, we could inject into the vein to, do an IV for liver, kidney, heart failure, lupus, rheumatoid, diabetes. We do nasal nebulizer and IV for stroke, Parkinson's, MS, Alzheimer's. The list of different degenerative conditions goes on, for what we work with. But to inject into the knee, you're going to create repair, because those cells will become new cells of where you have damage and degeneration. There are some great videos on the website that describe that. All of those videos as well we're putting out so you can see them specific to the podcast. There's a gentleman who had a labral tear in his hip, who was a jiu-jitsu practitioner. He had to stop. We did the stem. 3 months later, he was back training and was able to, within a few months after that, win a tournament. He won first place in a tournament because his repair became so significant from the stem cells. So the reason I put videos up for all the different disorders that we do is so that people can see it works for your heart, lungs, liver, kidney, pancreas, gut, joints, all over your body. And typically what happens with your knees also reflects what happens to your foot. And Dr. Ferraro could tell us about that as well, because issues changing in the positioning of your knee also affect how you plant your foot and how you walk and how you carry your weight. So very important to have the MRI done, and as soon as you can get that set up, in many cases we can get that set up for you, then we could either have a conversation. You can do a telehealth conference with me to go over that, or certainly people come into the office and we can chat and go over your case. Dr. Ferraro, how many patients do you see that have foot and ankle problems also have problems either extending to the knee or vice versa? I think that happens a great deal of time.
Yeah, really age dependent. But you're not going to find a 25-year-old with a degenerative knee and foot and ankle pain. But as we get older, the foot and the ankle are connected to the knee, and arthritis does not spare joints, especially weight-bearing joints, like the ankle, the joints in the foot, the knee. These are weight-bearing joints, so they take the brunt of the pressure.
And the fibula, which is that bone that runs down the side from your knee down to your ankle, becomes the lateral ankle, the malleolus, the bone of your ankle, and ligaments hold that in place, in a perfect world. And for those who have twisting or damage of the knee, where that bone sits at the top in the notch next to and articulating with the femur and the tibia, distortion at that knee joint will then affect the positioning and the function, certainly over time, with the ankle. And we've seen lots of people that twist and tear or fall and hurt their knee, and certainly their ankle issues ensue as a result of that.
Correct. Recently, there was a lot of talk of, going back to plantar fasciitis, a lot of talk about a varus knee causing plantar fasciitis, and that is one of the risk factors of developing plantar fasciitis. It has to track back up to the knee, and it's malposition of your knee joint, which can cause plantar heel pain.
Yeah, so all these subtle little changes people don't realize, and for the most part, doctors don't really talk about the significant connections, like that old song, "The Ankle Bone is connected to the..." I'm not even going to try to sing it, although I could.
Yeah.
So there, people come in and say, "I've got this pain, and it's in the side of my knee, and my foot also hurts, and I can't, walk, correctly." We have to look at the whole area. You can't just look at the foot or the knee. And to some extent as well, all of what happens in your foot and your knee happens to your hip and your low back. And over so many years, seeing people that are runners, and I love that people like to run. I'd rather have them run on surfaces that have a little bit of give as opposed to hard surfaces. But they end up with knee, ankle, hip, and back problems from sometimes excess running, more than what their body could handle. So I think, nice, comfortable, safe and smooth exercise without too much jarring or pounding, I think makes a great deal of sense, so as to enhance the stability of the joint and not to allow for wear and tear and damage.
Correct. I believe in the 70s, when the running craze started, you fast forward 30, 40 years later, that's also when the large jump in prosthetic joints started to take place.
Sure.
A lot more people with knees and hips. Yeah.
That's an absolute. I've seen that, over so many years. And there's some interesting research on individuals that go for arthroscopy to try to clean up the knee. In some cases, those people are much more likely to have knee replacements because of that damage and wear and tear that sets the stage for the arthroscopy, going in and cutting away some of that tissue, which in a perfect world is a nice cushion between the bones to separate. And those individuals sometimes will more likely have to go for knee replacement. So as I say, I'd rather catch the issue early on. And for so many people we've done this, whether we've started with the PRP therapy for the medial or lateral collaterals or, into the knee or the stem, and create that stability and strength so that you can decrease the risk for having surgical procedures. So we've seen that and done that over the many years that we're doing this.
Preventative care.
Yep. Once again, 888-420-9272 if you'd like to call in. 888-420-9272 if you'd like to. We have another email or
another from Instagram.
Type or text. Instagram is coming on strong today.
I'm telling you.
Gotta love Instagram.
So someone's asking, what can help COPD already using inhalers through nebulizer?
Okay, so COPD is a degenerative disorder of the lung. And as I mentioned in one of the prior shows, and we've got great COPD videos on our website, by the way, drcalapai.com, you can see results with our patients. The lung should be a nice, smooth, glistening, juicy tissue, which over time tends to become damaged. Inflammation occurs from a variety of sources. People who smoke, etc., people exposed to chemicals will have damage to their airways. Inside your lung, past where the bronchi, the mainstream bronchus, that tube that brings air to either the right or the left lung, they go into smaller bronchioles, tubes, that will end up opening up into an area where you have these little sacs, alveoli. And I don't have my lung diagram up on my little iPad mini. Oh, it would be nice if I would have thought about that to do that. But it can show you a good picture of what the lung looks like. If I have a moment here, actually, I can't get it quickly enough, but I should have some of these things, quickly available to pop up. At any rate, the alveoli are small air sacs that are wrapped with blood vessels. So let's say it's the size of a grape, and on the outer perimeter are blood vessels, and some on the inner. When the air gets inside the alveoli, this sac, the oxygen needs to cross over that membrane into the blood vessel so that oxygen gets into the red blood cell. So the red blood cell has iron inside it, and iron becomes the magnet to trap the oxygen to then fill up the red blood cells and then deliver oxygen to the rest of the body. It's like filling up a train car with lots of people. You're filling up the red blood cells with lots of oxygen to get them throughout your body. And as a result of the damage that COPD creates, you can't get the oxygen across that membrane. Doctors might use medications to try to decrease mucus production. They try to use something that could decrease inflammation. They may try to use steroids. But the problem is that the membrane becomes damaged and broken down. So the best mechanism that I've seen, bar none, and every mechanism, every research, every study I've ever looked at for COPD, is to use your own stem cells. So from your own body, from the crest of your ilium, the little bone that your belt sits on as you go back towards the bottom of that crest, we can extract that, take stem cells, spin them in a high-speed centrifuge, 4,000 RPMs, separate the stem cells from the plasma and the red blood cells, take them, put them into an IV so that it goes into your body through all your blood, and your lungs are very vascular, so your blood flow will go to your lungs. Stem cells will set up shop and get off the train, as it were, and help to create repair in your lungs. The second part of the protocol, which is done within minutes after the IV, is to breathe a nebulizer. And people have seen nebulizers for asthmatic patients where they're holding a little device connected to a machine, and the mist comes into your mouth, your airways. You're breathing this mist topically to your lungs. We put the stem cell and its liquid into that chamber of the nebulizer, so that goes topically to your lungs. So now you're getting both the approach to your lung from your blood vessels and the approach topically from the nebulizer. And in many cases, the results can be dramatic. There's a lovely lady who has had this treatment done. We've had her up on the website video, and she was unable to walk around, and she couldn't go down the block to go shopping, food shopping. And God forbid, trying to do anything beyond that, she was not able to do it. And then we did the stem over the course of a few weeks, feeling better and better. She didn't need her oxygen. She was afraid of being stuck on oxygen and having to carry the device around. And she says that throughout her interview. And she at one point decided to go see her grandchild play in a soccer game. And she parked the car with the family. She walked down the steps, walked across over to the field, had no problem. No oxygen, no inhalers, and she was able to walk back up the steps to get to her car. And she describes that entire thing on her little testimonial. So we know how well your cells can create repair, and allowing it to occur by two pathways. Number one, intravenous, going to all your blood flow over and over and over and over. And the stem cells jumping off and creating a brand new mechanism to turn into lung cells, and by the nebulizer. So that's by far the best mechanism to repair damage for COPD, emphysema, and even pulmonary fibrosis. There's research on that.
We got another one.
Another grammar? Another Instagrammer?
Another grammar. So this is from Savannah. She says, what's the most common mistake people make when it comes to foot care, and how can it impact overall health?
That's a great question. I'm going to have to defer to Dr. Ferraro for that because that's his specialty. The most common mistake people make regarding to foot care.
Good question. I would have to say diabetics. Patients who have diabetes and who they neglect their feet, and then they develop neuropathy. They wind up with a wound. They don't treat the wound properly, an amputation. I would definitely say diabetics. It's very, very important that if you're diagnosed with diabetes, or even if you have a family history of diabetes, which, as you were saying before, Dr. Calapai, the numbers are staggering. How many 2 million plus patients this year alone will be diagnosed with diabetes. If you have diabetes yourself or in your family, you should definitely be seen by a foot doctor. Have,
Of course.
Your peripheral blood flow. Make sure that you have good blood flow coming into your lower extremity.
Mm-hmm.
Make sure the nerves are working properly. If you don't have good blood flow, you'd be referred to a vascular doctor. Make sure that if there is something they can do to help increase the blood flow, they would do that. If you have neuropathy and you don't have proper sensation in the feet, there are things that we can do. Nutrition, the B vitamins, alpha lipoic acid, folic acid. These things all can help nourish the nerves. Maybe not necessarily to regain nerve function, but at least stop the loss where it is. But it's very important to have the lower extremity from your knee down to your toes looked at if you have diabetes or if you have a family history of diabetes.
So for all of our diabetic patients, go ahead.
Yeah, well, I was going to say one of the other things when you were talking about COPD and stem cells and amniotic, with wounds, whether it be a vascular wound, a venous ulcer, or a diabetic wound, there are wound graft matrices that actually have amniotic membrane that we use to heal advanced wounds that otherwise wouldn't heal in a patient.
Yep. Great new advance in a variety of different therapies for ulcerations and wounds. I was saying that all of my patients that are diabetic, I make sure they go to the eye doctor, the ophthalmologist, to get the exam, the retinal exams done. You have to do that. In many cases, we have them do cardiac testing in the office, the transcranial test looking for plaque in the blood vessels of the head, carotid for the neck, echocardiograms, abdominal. We also do nerve conduction tests to see if their nerves are starting to become affected. We do specific blood tests looking at C-peptide, fructosamine, all of these things, the inflammatory markers, C-reactive protein. These are people we have to work twice as hard with to really understand what their progression is. And of course, looking at their blood sugars, their A1C, the entire picture. So it's got to be a super comprehensive evaluation so we can prevent those things that may be starting. You got to catch them as soon as they start.
Definitely. One of the things we do in the office, it's called an ankle brachial index or an ABI. It's a ratio of the blood flow in your lower leg compared to that in the upper arm in your brachial artery. And that non-invasive test, essentially it's taking the blood pressure of your arm, comparing it to that in the lower leg. It can actually tell us a lot of insight into the blood flow that's coming into your leg and your foot.
Of course.
And if there's an abnormality, we then send you to a vascular doctor.
Right. You got to get all over it, as we say. You got to get on top of it. Alrighty, so thank you so much for being on the program today. Thank you for taking time out of your busy day. I know you have a lot going on with your family and the kids, but thank you so much. Dr. Ferraro, can you give us our phone number so people can contact you? I know you work in a variety of different offices.
Yes, so our main office in West Islip is area code 631-422-4450. We also have other locations all throughout the island. Our group name is Island Foot and Ankle. Okay. We have offices in Rockville Center, Garden City, Amityville, West Islip, Wading River, and Riverhead.
Wonderful. Really
Thank
serving
you very
so
much,
many
Dr.
of the different
Calapai.
communities. That's wonderful. Thank you so much. Good talking to you. Look forward to talking to you soon. Okay,
Same here.
have a wonderful day. Bye-bye now. Great information. Really great useful information. I got to put a bug in your head so that people that are developing foot issues or getting older or becoming diabetic, you have to have these evaluations done. Okay, phone lines are open once again, 888-420-9272 if you'd like to call and ask a question. Let's see if we have someone else out there that wants to chat. 888-420-9272. Good program, a lot of information.
It's just, it's hard not to laugh at how many people just love to ask questions through Instagram. I mean, this is our new, I love it.
Yeah, I think it's great. It's a great new, more comprehensive way to reach people. And as I said, what I had known for my entire career was just radio. So it was terrific. And we had callers calling in every week, sometimes same callers asking different questions, which was great. And, my job is to really get good information out, get the word out, tell people what you can do, how to learn about your body, what tests are important to do, how to make changes that improve, your condition. But this is such a greater, more vast new world. And as much as I like the radio, I like this better.
So obviously I'm the producer. I don't have a PhD. Someone asked, I was told I have MTHFR genes. Yep. Okay. Don't know. So how do you treat it?
There is a gene that everyone should have. It would be great if they did, and a lot of people don't. Probably 70% of people I see don't have this gene. And the gene makes an enzyme that helps to convert regular B12 to methyl B12. Methyl B12 is the best form. It's the most easily used. And if you don't have that gene to make the enzyme and you can't convert, then B12 is not going to function in your body. You may see a high B12 level in your blood because it's sitting there because it can't get into your cells. So the enzyme is called methyl tetrahydrofolate reductase, and that's the enzyme that creates that conversion. Regular B12 is hydroxycobalamin or cyanocobalamin. Look at this cute little buddy that I have here next to me. I can pick him up and put him on my lap, can't I?
Of course. We lost control of the studio puppy.
Come here. So studio puppy is here to do the show with me. And hey there. You are just gorgeous.
Oh, this is amazing.
So if you don't have that gene, you can't make the enzyme which would help to convert hydroxycobalamin or cyanocobalamin into full-blown methylcobalamin. So the way that we work with that is to give you a shot of methyl B12. And we also teach people how to give their cells the B12 shot. In many cases, we do a subcutaneous shot. You like the idea? A subcutaneous shot, or sometimes we'll do an intramuscular shot. It was at W.C. Fields who said, never do TV or movies with dogs or children because they steal the scene.
Yeah, there it is.
This is absolute. So, that's what you would need to do if you don't convert the B12. So methylating is an important process. So to go beyond that, if you don't methylate and you don't have the B12, you're not going to lower homocysteine. Hello. And homocysteine can cause plaque in your blood vessels. So homocysteine causes plaque. You need to have the methyl B12 there with B6 and folate to lower the homocysteine to decrease heart risk. And the list goes on because homocysteine elevation is linked with dementia, memory loss, and Alzheimer's, but also because the B12 is not there to do its job. So, great question. Everybody needs to know that. Do we stick around for another call?
Yeah, may as well. One more chance.
One more. 888-420-9272. Instagrammers are taking over. They're killing it. They're doing a great job. Lots of great questions.
Louis is just a natural star.
I wish I had hair as good as this.
Don't we all?
How many dog lovers are out there? We can get some calls from dog lovers. You can also put up pictures of my two dogs, my crazy dogs.
One more. All right, we got one more.
One more call.
If you have not worked out in years, what test should you get before starting up again? 56 years old.
That's a good question. So if people in their 50s are starting to work out and their hormone levels are low, you may try to work out and not get much of a result or a good feeling from it. If your hormone levels are great, you'll feel the workout. Your muscles will be great. You'll be energized from it. So in the 50s, we always test for vitamins, minerals. For men and women, we look at testosterone. For men, we look at DHEA as well with women, IGF-I, the active component of growth hormone. So we're looking to see where your body sits in the realm of having good hormones. We'll also look at your vitamin levels. If you try to work out and your vitamins and your hormones are low, you just won't feel it. And you'll say, I'm not going to get anywhere with this. So you think the exercise is not going to be beneficial. But if you have all of those things in the right range and you do the exercise, you'll feel like $1 million. And you'll be able to do the exercise, get the great result, and you'll want to continue doing that. On top of that, when we correct something like NAD, nicotine adenine dinucleotide, that will give you endurance and strength and the desire to go and get up and do. So there are a few different things that we can put together with peptides that also can make a very big difference.
You're not used to dogs that small. That was a comment on YouTube.
Yes, whoever knows my dogs, yes. I love little dogs because they're so cute they can sit on your lap. My two dogs is just... And Zeus, I thought Zeus was a big dog, and he's 7.5 years old. He's a German Shepherd. He weighs in at about 120, 25 pounds. He's a sweetie. He just kind of sits there, puts his head on my lap. Delilah is another story. She's got to be close to 145, 150 now. You can see that she's bigger than Zeus, and she thinks he's a baby dog, so she thinks she can just run around and jump on everybody. So when I know that she's starting to run, I always kind of take a look and make sure that I can turn sideways. So I know she's going to jump up on me, but she's adorable too.
We have another question.
Yes, another question.
How can you cure spinal stenosis?
The word cure is not really a great term for anything in medicine because it makes it seem as if the problem will be totally gone, never come back. So we don't use the word cure. So it depends upon where the stenosis is. So if you could imagine your brain turning into a big fat spinal cord like the thickness of my thumb and coming from your brain down all the way down to your sacrum, that spinal cord branches off into nerve roots, as you can see here on my handy dandy spine diagram. The yellow things are nerve roots coming off the cord. If you have foraminal stenosis, where the nerve comes off of the cord between the two bones, the top and bottom vertebrae, sometimes traction will help to take some of the pressure off. If you have disc degeneration or herniation, that can put pressure on the nerve and give you pain. There are different exercises, physical therapy, a variety of things that can be done to help with that. Yes, Reedy. And then if it's central down the middle of your canal, where that big, fat, thick spinal cord is, sometimes doctors have to go in and to remove that overgrowth of bone hitting the cord itself. So sometimes that's a surgical procedure. We try to do everything we can to prevent the surgical procedure, but, you may not be able to do that, right? So, yeah, if it's foraminal, that may be one approach. And if it's central stenosis, that's tougher because that's not easy to change without a surgical procedure. No questions about dogs?
Not yet.
Okay, we'll save that for the next show. All righty. Thank you for tuning into the program today. I'd like to thank my special guest, Dr. Anthony Farrow. I'd like to thank my little doggy special guest. How are you, buddy? And thank you for tuning in. Hope you had a terrific time watching all of this. Please tell your friends and family about the podcast, where you can watch it, YouTube, Spotify, all the other areas, Instagram, Facebook, and let everybody know. And think of some questions because we're here to take them. I'll be back here Monday and then Friday and next Saturday till the end of time. All righty. Bye-bye now. God bless you all. Have a wonderful day. Say bye-bye.